after UK.
Thank you very much, Mr. Chairman. Great pleasure to be here. Yeah, so we're now going to look at avoidable reasons for poor outcomes. Now, I should begin by saying most of these cases are not mine, but of course, unis have a very bad reputation, mirrored of failure modes, and so we need to have an algorithm for dealing with these and trying to prevent them. Now, we were first made aware of the potential for poor outcomes in 1985. This is a 4-center study performed in Europe. You can see that at the top, 4 surgeons were able to perform. This was in fact the Oxford. They were able to perform it very well, but 1 surgeon did not do nearly so well. So poor outcomes are certainly possible after any form of surgery. And then again, about 10 years later in 1995, this is from the Swedish knee arthroplasty register. You can see here Leewold showed 10% failure. Again, this was the Oxford, which was the most commonly performed uni at that time, showing 10% failure rate at 6 years. And they suggested that that was way too high, which it certainly was, and you should not use it. Now, of course, one was interested to look at this in a bit more detail. This is a scattergram showing the failures here in the y-axis, and on the x-axis the number per center. And you can see all manner of different successes or failures. This was somebody who was doing large numbers and getting good results. This was a center getting catastrophic results, but you can see relatively few numbers were being performed. So this is one implant, not unique to the Oxford. I'm sure it's the case with many different forms of implants and many different techniques. But of course, we can't blame the implant, really. This suggested to us a long, long time ago that inappropriate indications and or technique were the likely blame here. And of course, ever since then, we've been keen on instructional courses, and Rami's mentioned that. So first of all, you need to look at the indications. I won't labor this, Rami has mentioned it, but basically indications are really straightforward in terms of a uni. This is whether it's fixed or mobile. You need to have advanced arthritis, bone on bone. You need to have a good-looking lateral compartment, and the ACL needs to be functionally intact. So I won't labor that. But I would hazard a guess that in this part of the world and in Asia, there are huge numbers of patients who have x-rays looking like that. If you see that type of x-ray, you can be thinking in terms of a uni. So you do the stress x-ray and 20 degrees, wedge, 10 degrees parallel, so you can get a good stress. Now, just to add a bit to Rami, there is now a radiological decision aid. It really is rather useful. It shows you that the decision to operate for a uni or not is based entirely on x-rays. So do your stress x-rays. You then look to make sure there's bone on bone. So if there is bone on bone, you can do a uni. If there isn't, don't do one. You look at the lateral for the ACL. If it's intact, you can do a uni. If it's not intact, you can't. You look at the lateral side, full thickness obviously here and here, you can do it, here you can't. And the patellofemoral joint, perhaps some differences here between fixed and mobile, but essentially the indications are beginning to coalesce. If you have this, if you put this in the notes, God forbid if anything were to go wrong, then this is very useful to explain both to the patient and to the lawyer perhaps why you did the uni. Now, you must not do unis in early arthritis. Many surgeons think they'll do a uni just in case. They'll do it as a pre-total knee. If you do that, you will get really bad results. And this is a remarkable study from Finland showing that they had a terrible failure rate with unis, 20% reoperation rate. And a very bright young student wanted to know why this was the case. So what he did was he looked at the standing x-ray before surgery and he measured the joint space. So this is pretty severe, 1 millimeter or less. But as you go to the right, the joint space gets more and more normal. And look at this. These people were operating on virtually normal knees. They would never, ever do a total knee, but if they have normal-looking x-rays, you will get bad results. So please only do a uni if and when it's as severely damaged as for a total. So what about the results? Well, if you look at the results, this is Keith Berendt. Most of the failures in unis are due to loosening on the tibia or pain on the tibia. So 2/3 of failures in unis will be tibial related. So you need to have an algorithm to deal with a tibia. So you need to, this is one of my cases, way too far medial, way too far deep. You must be careful about that. The tibial resection is the most difficult part of any uni, whether it's fixed or mobile. It comes right at the beginning of the procedure, and you need to be careful with it. The positioning is a problem, the orientation is confusing. The vertical cut here in the old days used to be too far medial, and as I said, the tibia was too deep. This is the most important picture I'm going to show you. Every time you do a uni, think of the poor proximal tibia. This is FEA. And what happens is you have a compression band here and you have a tension band here. As soon as you cut the proximal tibia, you increase strain in that proximal tibia by 60%. And there is a spectrum of problems with unis on the tibia, from postoperative pain through radiolucent lines to a stress fracture and finally a full bone fracture. So whenever you do a uni, remember you must have the most conservative cut possible. Never ever recut the tibia. If you have problems with the flexion gap, go up into the femur and remove cartilage from the femur and elevate the joint line. If you recut the tibia, you massively increase the strain. If you go too far medial, you massively increase the strain. If you cut the posterior cortex, you massively increase the strain. So I won't labor this, Rami has shown you this, but basically we introduce the spoons, which are a stylus, and the clamp so that you can get a very accurate cut of the tibia. And I would suggest to you that not only mobile, but fixed bearing should have this form of device. Never ever recut. So here we are, this is what it looks like. You've got your spoon, you've got your G-clamp, and you've got your extramedullary rod. So the only other things that you need to look at, you need to make sure you're as far lateral as possible. Think half a total knee. So what I do is I get a bovie and I diathermy the spine until I see it. Go as far laterally as you possibly can. The orientation of the vertical cut is not nearly so important. We now aim a bit more lateral, so we internally rotate it to get better coverage. Never recut the tibia. Obviously, you need to be careful with the horizontal retractor. So we are shooting routinely either for a 3 or for a 4 bearing, and you can get that in about 98% of cases. Never go more than a 5 if you're using the mobile bearing. Rami's shown you this. If you use the femoral drill guide, if you use it, link it to the IM rod, you can massively decrease the variability of femoral component positioning. Posterior cut is fairly straightforward. Obviously, with a mobile bearing, this is more important. You must remove impingement anteriorly and posteriorly, particularly posteriorly, if you want to prevent dislocation of the bearing. This is the second most difficult part. Again, it's related to the tibia. You need to make sure that the tibia sits, so it's resting posteriorly on the posterior cortex, medially on the medial cortex. Take out as much of the bone as you need to. Cementing, I would do it in 2 stages. This is critical. Thin layer of cement on the bone. Make sure you have a thin layer of cement on the prosthesis. Make sure it's resting posteriorly and medially, and remove any posterior cement. Cementing the femur, again, you can do that once the tibia has cured. Make sure that you put cement fully on the undersurface. So in summary, poor outcomes are essentially due to either poor indications or technique. Please do not operate on early arthritis. Make sure there's bone on bone, and then you'll get good results. The most common failure modes are due to tibial problems. Make sure that you do that carefully and sensibly. Make sure you put the largest tibia you possibly can on, and if you do that, you will get reproducible results and you will minimize poor outcomes. Thank you very much.